The first keynote, and I'm delighted that we've been able to welcome Dr. Minal Bakhai MBE, who's a general practitioner, been in North West London I think for about 12 years now, but is the National Director for Primary Care Transformation at NHS England. And of course we know a lot about the ever-changing world of general practice. Linda Charles-Azuzu used the word PCARP, which feels as though it's the only game in town at the moment. Have you come across PCARP? The recovering access to primary care, sort of subtext general practice in the main, but we need to recognise that there's a whole range of new first contact services, not least pharmacy first in primary care. So I'm going to have a chat, some thoughts from Minal, particularly in the reviews that we're having. It'd be a little bit GP-centric if we go into the GP contract, but what is being done within the debate around addressing health inequalities. Yesterday we heard from ICB leads about how important it is for the commissioning of services in the future that health inequalities needs to be addressed. What we mean by that, there's a lot of dialogue to be had, but certainly from the transformational outlook of the national leader and how that might fit with some of the work we're doing, please welcome to the stage Dr. Minal Bakhai. Minal, you're very welcome. Are you okay with the handheld mic? Because I thought we'd, on that background, just leave you to give some first thoughts and what's challenging you in your role. Transformation we were talking about yesterday, which is always a word that says, well, we're going to a completely new state rather than improve what we've got or try harder at what's already failed. But particularly in the transformation of services that focuses efforts more on those who are disconnected, of high need but not well served, and recovering access. There's some people who have never had access or limited access, and a lot of the work being done in the room is by trying to connect. And I make no apology about hard to reach. When you say hard to reach, somebody's always going to say, we don't call it, is it hard to reach? Who's hard to reach? Is it hardly reached? Is it people without? Get over it. It's just there's a number of people who aren't connected with our service through the usual way of registration. And recovering access, there's a sense of, what about people who've never had access? What are your thoughts?
I'm going to use that next time. Get over it. Thanks, James. And so, yes, I'm a GP. I work in Harleston, in Stonebridge, in Brent, in North West London. And I don't know if any of you have ever been to Harleston or been to Stonebridge, but it's one of the most deprived. I know everyone says I work in one of the most deprived areas in the country, but I really do work in one of the most deprived areas in the country. I think our PCN serves the most deprived population in London. And Harleston comes second to Grenfell in terms of the most deprived ward in London. And most of my population haven't completed education, not had the same training opportunities that the most of society has. They're not in employment, or if they are, they're on low-income contracts, low-income jobs or zero-hour contracts. So essentially, I feel like I've spent most of my clinical life advocating for some of those really underserved communities in society. And I'd say about 3 years ago, as a practice, we were asked to merge with a practice that had been rated CQC inadequate. And for all of those in the room that have had to merge with practices in a similar situation, I think you'll know what the challenges are. And it completely tipped us over. Our access just, fell. But I think at one point our waiting times were 6 weeks for appointments. Staff were really unhappy, felt that the complaints were going through the roof. There was not much that they could do about it. Obviously, patient experience fell. Continuity went right down. We felt the quality of care that we were providing was not very good. We didn't feel particularly safe. We felt we were firefighting all the time. It took a personal toll. I have 2 young kids. I just was not seeing them at all. By the time I got home in the evenings, they were fast asleep. And that was really difficult. And so we decided to completely change the way that we worked and overhaul the kind of traditional model of general practice as it was. And we implemented what we are now calling modern general practice in what Linda called PCARP, the recovery plan. And what that did was it completely transformed our way of working. So our appointment wait times are now 48 hours. Most people will get a response and a plan within 24 hours. Continuity has risen from about 27% to 70+%, which we're really proud of because that matters a lot to us, particularly because we've got quite a complex needs population. Complaints have gone right down, patient satisfaction is much higher, job satisfaction is much higher, so we're seeing far less churn of our staff, we're able to recruit, and that's actually quite a feat where I work, because down the road is Chelsea and Fulham, so it's always been difficult to recruit into an area like ours. So the fact that we've managed to transform the way that we work actually attracts people to come and work with us. And essentially, that is what modern general practice is. It is a model that has been born from the hard work of practices and PCNs in response to the pressing challenges that we're facing. We as a practice, we're not alone in facing these challenges. So we've seen demand increase by over 15% in terms of clinical consultations when we look at the national data. Most of that demand is being driven by our older population, which suggests that we're also seeing a rise in complexity. Now, I think 1 in 4 adults have 2 or more long-term conditions. So, that trajectory is going up, not down. But also, capacity is a real challenge. We've lost almost 2,000 GPs since 2015. Stress, workload, burnout are the most commonly cited reasons, unsurprisingly. 20% of our GP workforce is due to retire in the next 3 years. And, GP trainees are telling us in all of their surveys, they don't want to work 10 clinical sessions. They want portfolio careers. They want a career pathway. They don't want the liability that actually we as partners have traditionally held. And so we do need to think differently about how we work in general practice. But if that was not enough of a burning platform, we know that our population over the next 15 years is growing by about 3.4 million. 3.3 million of that is the over 70s, so brilliant, we are living longer. But we are living longer with multimorbidity. The average 80-year-old will have 6 long-term conditions. And we're not set up to manage multimorbidity, really. We're still focused on single disease or single condition pathways. And I don't foresee a huge injection of funding coming into the NHS because ill health is growing by about 37% over the next 15 years. Our working population is growing by about 4%. So the revenue generation for public services is not keeping up with the growth of need. We're already at Scandinavian taxation levels. An economist told me the other week, even if our economy grew by 8 or 9-fold, it would not be enough. And I don't really see our economy growing by that much that quickly. So that means we absolutely need to transform the way that we deliver services. We need to better align existing capacity to need. We need to, of course, improve job satisfaction. We need to retain our experienced clinicians while we train up new ones. And we need to improve the experience for our patients. And so, for me, the delivery plan for general practice primary care is the first step in that journey. And actually what I think it does do sensibly is it starts to align multiple different enablers that we need to support that large-scale change, that leap, that transformation that we're looking at. Because I don't think it is incremental improvement, James, in terms of the pace at which we have to change. And And essentially, modern general practice is a set of organising principles, an organising framework, inclusive access. So having a choice of different access routes. What we know is that patients choose different ways of accessing us dynamically. So when people perceive they've got a more urgent need, they'll often phone up. A less urgent need, they'll go online. But only if that experience of going online is good. So we know that over 70% of people will go back online if their first experience was a good one. It's then about capturing that structured information at the point of contact, so we understand what's being asked of the service, so we can enhance the way that we navigate people to the right service, the right person, first time. It's about using technology and data to make our processes more efficient, but it's also about building the capability within our teams. So primary care, general practice, has been underinvested in terms of skills development. So I was again saying to James last night, I was telling Amanda Pritchard, most of the training I do is in my own time. I pay for it myself. And so how do we expect people to build the skills and capabilities that we need to actually transform? In acute hospitals, recently I found out that 90% of the leadership in acute hospitals, and managerial leadership as well, is clinical. So, that is not reflected in primary care. So we need to be able to develop our leadership, but we also need to invest in building those skills and capabilities for transformation and continual improvement. And so some of the work that we're doing nationally through the National General Practice Improvement Programme is taking the learning from the great practice that's happening across practices, PCNs, other at-scale primary care providers, evaluating it, codifying it, and translating it into practical support to then be able to spread those benefits more widely. But that support will be tailored and adapted to the local situation, but we also don't need to start from scratch 6,500 times. But why I think this is exciting is that it is not just about unscheduled reactive demand, because I think we're really struggling with getting that balance right. We feel we're drowning in reactive demand and not able to do the kind of planned care, scheduled care, let alone the proactive care that we need to. But as you start to work in this way, first of all, when we've looked at over 10.5 million contacts across practices working in this way, we see patient experience higher, so it's 6 percentage points higher than the national average. Continuity of care is higher by almost 23%. That practices are tailoring care based on needs, so you can see that the elderly, the very young, new presentations, patients who are unfamiliar, who are complex or who have continuity care needs are being prioritised, and that the mode of access does not determine the mode of consultation. So you can start to see that personalisation occurring, but really importantly, you can start to see the responsiveness of services, which builds that trust and confidence in patients. But when you start to then apply this same methodology using data, and particularly population health approaches, so segmenting your population so you can understand who is higher risk and who is lower risk in terms of need, then you start reducing unwarranted variation in how you care navigate. It's less subjective. There is more transparency in how you do that, and that builds confidence. But when you apply it to scheduled care, we're starting to see practices complete all of their long-term condition reviews for high-risk patients before winter, reducing exacerbations. Practices completing their entirety of QOF by October, which therefore creates resilience over the winter months. And what that's led to is, I think, a 10.7% reduction in activity in general practice, a 30% reduction in unplanned admissions, a 33% reduction in bed days, and about an 11% reduction in A&E attendance. So it has system-wide benefits as well, but practices feel more resilient. But with that reduction, when you start to combine all of these sort of benefits, it's starting to create that headspace for proactive care. And what you can start to do is identify those people who are high risk. You know, they're your frail patients. You know they've got lots of medical conditions, but they've not consulted with you for over 12 months. What's going on there? Those people that are over 50 who haven't consulted with you for over 5 years. What's going on there? Because typically they are some of your more vulnerable communities. And I was up in Lancaster the other day, and I went to see, I went on a visit to one of their estates. And as a mum, actually, it was really heartbreaking because the kids were surviving on a piece of bread for dinner, which is, you know, unimaginable, actually, I think. They had to turn the electricity off in the evenings. They weren't allowed to watch TV because they can't afford the bills. That community, the whole of that community had not engaged with health services for over 5 years. So this was identified because they were able to have headspace to take that proactive approach. They developed community connectors. In this case, they used a practice nurse, but she wasn't using her clinical skills. She was using her relational skills. And she spent 18 months building trust and relationships with this community. And they were really afraid of connecting with healthcare professionals or teachers because actually they thought they would report them to social services and their kids would get taken away because they knew that they couldn't afford what they really wanted to be able to do. They couldn't even afford the bus fare for school. And so then through this connection, they were able to connect in with other kind of voluntary sector and charitable services. There was fundraising, food packages, etc. But also because they were able to build the trust, they were able to then raise awareness of kind of health screening programs. Now 50% of the community has had a health check. 1 in 2 have an undiagnosed long-term condition that's now been identified. And you can start to see how you can make such a massive difference for such a vulnerable community that's just not been given the same opportunities as some of us have been privileged to be given. But it's about creating the space for it. So while we sometimes see sort of these policy initiatives as they can feel quite transactional, they can feel quite cold, the narrative is never brilliantly described. But actually it's part of a much bigger transformation journey to support us in providing that holistic care that I think all of us have gone into work. That's why we work in primary and community services. This is what we're here to do. And then to build those more, that integration. But I think, and again, James, you know, we were talking last night about those 18 months of building relationships. That's not an appointment. That's not an activity that you can count. And so there is an issue about how that is valued so that we can do much more of it, because it's hidden work, really important work, but hidden work that in the long term will stand us in really good stead for that proactive, preventative work that we want to do, but it's not necessarily recognised by our contracts, our incentives, our kind of current measurement structures.
Minal, thank you. It's always impressive where somebody is so clearly on top of their brief and can articulate the issues that need to be addressed without the safety net of PowerPoint. So I find that's really impressive to set a scene for some questions which we'd like to take from around the audience, as we did yesterday, waiting for the mic. Please introduce yourself to Minal and any questions. But to start, there's just a sense that we talk about primary care as a style of practice in its broader sense, but often default to general practice in the GP contract. In the audience, whilst there's lots of GP colleagues here, there's lots of colleagues who may be not non-clinical, but are leading really impressive projects through the demonstrator sites of the CCC programme. Is there a sense that the GP contract or the funding going into primary care networks might start to recognise that multi-professional interdisciplinary team approach that say that some of the impressive things we're seeing is not driven by a GP contract, and it's because a lot of the need, as you were saying, if you do the right analytic of the population need, it's not best delivered by a primary care physician. I remember some years ago it was the NHS Alliance who had done a report on GP's perception of people presenting to a general practitioner and how much actually needed the skills of a primary care physician. And it was somewhere between 30 and 80% didn't need a primary care physician, but they went there because there was no alternative. And then the GP was the broker to the right care. And we talk about care navigation. But anyway, is there a sense that the GP contract, because I know there's a lot of discussions about the future of the GP contract. I think it was yesterday Amanda Doyle was saying that there's going to be a review of GP services in this broader sense, whatever that means. But that might, there was a word we used yesterday about reframing the debate. Do you think we're in a position that we might start to think differently about resourcing primary care as a network and then delivering against some of the most complex issues without having to go, can we find a quaff point for health inequalities? I was asked that recently on the review. You know, how do we incentivise for health inequality and quaff points? And my answer was, you know, let's not even go there. But anyway,
yeah, I think it's difficult to predict what's going to happen with the GP contract, but I think there is an opportunity here. So I think there's certainly many, many more conversations that I'm in that are talking about high trust. So moving, and I think the incentives consultation is almost the first step in that, to look at, can we reduce the kind of micro-managed incentive schemes that exist? And so, you know, obviously, I hope everybody's had a chance to feed into that and share their views. But I think there is much more recognition that often the GP contract has probably been built around the kind of less than 5% practices that may not be high performing, but manages everybody in that way. So I think there is a real opportunity for more high trust, improvement focused type contracts, where you build the trust, but you've also got the transparency around the data, and the investment in peer-to-peer learning, and driving a much more improvement focus, but also with that kind of local perspective, which is more centred around population health. I think, you know, it's always hard to predict because some of this is so political, and we're in a very tricky political situation where there's a lot of flux. But I feel for the first time the right noises are being made around the direction of delegating that trust along with the accountability more locally. I don't know if that really answers the question, but I think there is a real opportunity. I think what we see at the moment with the current GP contract is particularly like with the DES, for example, that is being simplified and becoming more around, you know, what's important for the PCN to be able to do. I think it's going to be interesting as integrated neighbourhood teams or neighbourhood services evolve to see who the kind of dominant partner is in that. And I think that's being reflected at place as well. So one of the challenges that I see when we're in a really financially constrained environment is that CFOs in systems are less willing to delegate budgets to place because they want to hold the money within the NHS rather than necessarily risk that the money being distributed to other place partners. Now, I guess that comes back down to the bit of a short-termism element because you've got to balance the books. But actually, in the long term, what we do need to do is really invest in care in the community. And as you say, James, that might not be medical necessarily. It's that broader care in the community. So I think there's quite a lot to do around culture and leadership as well as really demonstrating the value of the investment. And I think, what the work that this group has been doing is actually really key to be able to demonstrate that investment, what you can achieve on actually quite small amounts of money, but that has a really big and lasting impact. And I think the more that we can demonstrate around that, the more kind of drive there will be, and confidence, I think, to be able to do some of that. But, some of this is sitting tight. Not everything will work first time. Transformation is does take years, so we can't keep chopping and changing. We need to do it, we need to learn, we need to iterate, but we need to kind of be invested in that stability. We absolutely need more stability of funding. The annual cycle is really challenging to be able to plan and do meaningful work. And then I think it's that parity, both parity of primary care on the ICB board, or primary and community care on the ICB board, but then also parity of partners, system partners at place level.
Great. We'll come out to the audience because there's a few hands going up now, and I'll David, if you go that side, I'll go this side. I think even the language of building trust into contracts. Colleagues from Burnley, somebody was over here first, though. We'll take a few. Thank you. And if you can introduce yourself.
Absolutely. I'm Jane. I'm from the Lowestoft PCN, and I just wanted to comment on both yours and James's comment before about non-clinical interventions and non-clinical staff. I'm the health and wellbeing coach across 2 practices in my PCN. And at the moment, the average wait time for a GP appointment, for a routine GP appointment, is between 2 and 4 weeks. But it's very telling that by the end of January of this year, my first available appointments were April. I am usually booked 2 to 3 months in advance, not because I'm more in demand than a doctor, but because there's only one of me. And I'm doing as much as I can for them. If there was more of me, I would be taking a lot more pressure off the GPs. That was just my comment.
Yeah, no, I think that's really valid, and I think my other reflection on that, just from my own experience, is where we have we recruit a lot of our staff from our local community, and what we've tried to do is actually build an apprenticeship scheme. So we bring those community members in, we train them up. I'm so proud of so many of them. They've gone on to be nurses, healthcare assistants, health coaches, but they have been absolutely critical to improving our screening, our smears, our immunisations, because similar to that community connector role that I described in Lancaster, you could translate that to look or adapt that to whatever it fits for your local need. But bringing people from the community and then helping bridge that connection to raise that awareness is so important. But again, we have to value that. We have to see that as hugely valuable. It's not a nice to have. It's critical to be able to then do the stuff that we know is, life-saving.
Hi, I'm Yaz. I'm a GP in Burnley, clinical director, Burnley East PCN. Thank you for sharing your story, and it's great to see the impact that you've had on the waiting times. I just wanted to share some thoughts with you and everybody in the room. Yesterday, our ICB came to us and gave us some details of the new contract and some changes in our local GP contract. So, like you say, you've worked really, really hard to try and free up some of the GP time, make sure that the waiting list is less. We were very, very lucky in Burnley that we've had an established over 75 care home community ANP team, and Lorraine's one of our nurses from over 9 years. And this team has been phenomenal. They have been there 9 years. They work mainly in the care homes, but they do go around to the community. And they've established relationships with staff, care home staff, families, patients. There is proven evidence that they have prevented avoidable admissions. They've improved the quality of life. They've done frailty checks. They've done advanced care planning. They've reduced the number of 999 unnecessary NWAS calls. And we were transformational in Burnley and very proactive. However, you know where I was going with this. With the levelling up and trying to kind of paint everything with this one brush, one size fits all, we have now been penalised, and we are at massive risk now because we've been told that our over 75s funding will now be stopped. And we will be getting paid on a segmented basis for, say, frailty check or X review or whatever review. Now, we have staff, like I say, 9 years of experienced staff that have been there, built those relationships. You're not going to get that from anywhere. How does this make sense with this transformation, levelling up, all the rest of it? What are we supposed to do? And how is that going to reduce waiting time for GPs? Because it means that now, if we don't know the future, we're going to have to find thousands of pounds to fund these people, because really they have a right to redundancy if we cannot continue. And who is going to do that work? Is it going to be GPs, care coordinators, ARRS staff, or is it going to be the national 2-hour rapid response team? And I don't know what it's like in other areas, guys, but they have a long list of criteria. And if you don't meet the criteria, I'm really, really sorry, you're going to have to go back to your GP. So I just want to highlight that it's great, and I totally respect, and it's great what you've done, but why can't people keep things in place when something is very clearly evidence-based and it's shown to work? And, you know, it's really important. When I say 9 years of experience, we're crying out for clinical staff with that experience and expertise. We've invested 9 years in that staff, and now we're going to lose it. How does that even make sense?
Can we take a few more? Because I know there's a few more hands going up, just so... But yes, thank you for that.
Hi, Karen. I'm a GP and CD in Southampton. I've just got a couple of points, really. I think when we're talking about the GP contract, there is, without question, a huge amount of anger at the moment with regards to that, and the 2% uplift that we're going to give is a kick in the teeth. We're talking about deprivation and health inequalities, but without question, with regards to the complex comorbidities that we are facing, you absolutely need a GP for many of those things. And we do not have the funding for that. There are GPs around the country that are now folding. They can't afford to pay their staff. And this is a significant problem. So when you talk about trust, there is absolutely zero. I mean, zero. We have people in NHS England, in the Department of Health, that are making decisions without consulting any GPs. When you talk about leadership, there are massive amounts of GPs around the country that are willing to act in that role, but we aren't being asked. There is secondary care absolutely have got, as you say, 90% of leadership coming from clinical, and that's not the case in primary care, but that's absolutely nothing to do with us, because we are just not being asked to do that role. So actually, when we're having decisions that have been made without us, we are incredibly cross, angry, insulted. So I think there will be no trust. And I think if you're looking at health inequalities, you've also got to look at the Cahill formula. I mean, essentially, the Cahill formula, I work in Southampton, and our ICB is now encompassing Hampshire and Isle of Wight. And actually, there are areas in the north of Hampshire, leafy, very well off, that are being given far more financial money than Southampton, which has got really high areas of deprivation. So there is something incredibly wrong with that Cahill formula. And what we're hearing is, year in, year out, that the government are looking into that. Well, nothing happens every year. So if we can't be given the finances to help with the deprivation, because it's not being taken into account adequately in the Cahill formula, essentially those areas of deprivation are screwed. And that is a massive problem. So there are absolutely amazing people in this room that are doing an awful lot of work to help, but actually but we're being funded at the moment to do a lot of that help. 20,000 that I was given for my project is amazing, but actually a lot of GP surgeries don't have the finances to do these projects. And I think those examples in Lancashire is absolutely amazing, but I think unless the funding to GP services improves, I think health inequalities is going to continue to be an absolutely devastating problem, and the GPs, and you need GPs to help with that. So talking about absolutely lots of other roles which are incredible, you still need to support GPs and general practice.
Karen, thank you. I'm going to take one more GP, Chris, but I'm going to take full responsibility for people like Tara, who raises the energy and the enthusiasm, and then I bring the GP contract in and we go nosedive.
And just to be clear, I am not responsible for the GP contract, and that is not part of my role or job.
We're talking about transformation, so I want to keep the energy up, but I guess it's how we solve some of the issues. And I think it is in the high trust, which we talk about then, sort of budgetary responsibility, but not the transactional tiny nature of every single aliquot that you have to... Chris, we'll just come to you and then we'll
Sorry,
come
just
back to
slightly
some
boring
thoughts.
process question after a very eloquent intervention from my colleague there. I was really admiring your figures, fantastic improvement, but I wasn't quite sure how you actually reformatted the services to achieve them. So if you could just maybe put in a nutshell how you manage that fantastic change, I'd be interested to hear.
Yes, yeah, we've had, I think, 3 general practitioners, haven't we? And I guess there's a sense of the enthusiasm to make change and sustainable change with an understanding of limited resources, but not turning into sort of a transactional process, which sometimes then takes things away because the money's being shifted elsewhere.
I mean, I think there are, I'll share all of your reflections. I'm a GP who works in a really deprived area that's underfunded and has a high, higher need than average, let's put it that way. I think everyone would agree with you, Karen, around the Cahill. I think the challenge that I hear, because it is raised all the time, is that if there isn't enough money in the pot, there are winners and losers if that money is redistributed, and as a profession we have to be then willing to hand over some of the funding from more affluent areas to those that are more deprived, and the profession I don't think is united on that either, and some of the strongest lobbying groups are not necessarily from those most deprived areas. I think it's complicated sort of politics in that space as well. I think there is an opportunity, though, to distribute funding growth more differently and proportionately sort of fund areas of higher deprivation, higher need, higher complexity. And actually there are some systems like Leicester, for example, Leicestershire, who have done some really good work around developing a kind of a need-based formula where they have started to redistribute funding to those practices with higher need differentially. Still early days to see what that results in, but there's positive kind of qualitative feedback on that. So I think, there is opportunity even within what we've got, but we need that leadership at every bit of the organisation to help drive some of that, but I don't disagree with that. I think we all reflect on the uplift of the contract, and I think Treasury would be good if they could support. But again, I don't, the ability I don't actually think that's in the gift of NHS England, if I'm really honest on that one. I think that is in the gift of government. It's really disappointing to hear what's happened in your system, but I think, again, that's where you need the leadership. Yeah.
The clinical leadership, like Aaron said,
Yeah. It's missing. And one of the things that I'm building is a primary care transformation peer ambassador academy. I've asked all the systems to identify not necessarily clinical or non-clinical, but primary care leadership, people who aren't formally in a leadership role but are just doing really brilliant stuff on the ground in their PCN, in their practice, in their community, who've made those changes. And to bring them together nationally, so ideally just starting even with 10 per region, so 70 nationally, One, because it's really exhausting, and I'll come on to how we did the change, but it is exhausting, to sustain them, to share that learning about all the brilliant stuff that they're doing. But what we need is inspiring, motivating leaders that can demonstrate the opportunities of transforming and changing and what that can bring, but also then to create a pathway to help develop them to become future system leaders. And so asking the systems to invest in those individuals, so both time and money, and then we'll facilitate nationally through mentoring and other opportunities, development opportunities, but with the kind of proviso that they then have a career trajectory, if they choose to take it, that embeds them in system leadership roles so that they don't get lost, but they are people who know how to do change, who've done change, who've lived and breathed it, and are really can also inspire and motivate others. And I think that's a new type of leader than perhaps we've traditionally chosen as well. But of course, all of that takes time. But I, really keen to see far more senior primary care leaders within systems to hopefully speak up for the situation that you're in Burnley, and have a stronger voice to fight for primary and community care investment as well. And then in terms of how was your question, how I did the change in my practice? So I had to do it without any support or resource because it didn't exist when we were in crisis. Data. So I spent a long time looking at our data, so understanding our demand, understanding that need, and reviewing our capacity. Simple scheduling stuff, like most of our demand was on a Monday and Tuesday, but our capacity was just spread evenly during the week. Didn't make sense. It was not that we weren't matching it. Started to understand the type of need that we had, so it could better either develop the skill sets within our workforce, within our team, or to recruit people with specific sets of skills. Mapped out our processes to understand where the pain points were and what was going wrong. Designed with the whole team, administrative team as well as the clinical team, our protocols and processes of how we wanted work to be distributed, called out variation, particularly between clinicians, where people were doing very, very different things, to start to kind of learn from each other, but also have a much more consistent approach to how we were managing our work. We really embedded digital tools and used those to enhance the way that we were working, did a lot of work with our PPG and our community, and developing patient communications to really take people along with us on that journey. I've written it up so I can share it with you if you want, like a kind of step-by-step account of what we've done. What I would say is that it was really challenging. It was hard work, but part of what I'm trying to do with the improvement program is to make that easier. So to kind of to codify that and provide practical support to help people go on that journey and make the change more easily and see the benefits.
Minal, thank you. We're almost up to time, but I think we'll let it go again because I've said about the agenda, that. But for absolute persistence in raising a hand, Paul, Tom and Farry probably is the last three comments. Paul, and if they can be fairly succinct, and it may be just final comments for this particular session. Was it ladies first, Farry?
Hi. I think so the unspoken dirty word in this environment is politics. We are talking about need versus demand. We function in a system where politicians promise a Rolls-Royce service and probably fund us for, I'd like to say a bicycle, but people might say that's being kind. And so we end up with, very ill thought out measures like, this is how we're going to measure access. We've got bean counting happening, and we are in the throes of this all. I like the fact that we're talking about high trust, but I find it very difficult to see how that is going to come and then affect your day-to-day firefighting while you're trying to manage this demand. And I'm not even going to talk about certain newspapers and people who then, GPs are their favorite people to lambast regularly. So just a small issue there. I'm not sure you have the answer, but it is, we've got to recognize this environment we live in.
No, thank you. Tom?
Yeah, I think what you're doing is great, and I think the premise should be, the responsibility of the ICS and government and NHS England should be that transformation shouldn't be exhausting, because you only make it exhausting if you don't want transformation to happen. And I think we have to move away from this goodwill, martyrdom stuff, because there isn't any more goodwill, and everyone's, so the risk is and then going on from that, the biggest risk to health inequalities is that so much stuff happens that is not in a contract, but it happens because people still feel it's part of being a nurse, a doctor, a well-being, blah, 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 all these sorts of roles. And that tends to help people who are most at the edges, who are most at risk of being adversely affected due to health inequalities. And the system, ICSs, are under pressure to just make things look neat. But the reality is we live in a messy world, and it's just a big muddy puddle. And unless ICSs have a responsibility to find the invisible work, the unseen work, and to understand it, and then when they have X amount of money, whatever that looks like, they then need to build systems that understand where activity is, whether it's contractual, unseen, or random, chaotic, or whatever. And then they need to manage that everything in a sense and see that and allocate towards it. Whereas the problem for primary care is, and community, and especially the third sector, is that most of what they do is unseen. But eventually people will start to stop doing stuff, and then there'll be a crisis. There's some amazing examples in here. The health bus, which is my favourite thing. Them working with people who are at risk of homelessness. An ambulance delay is not the same. It's not 20 ambulance delays that are all the same. They're all slightly different. And unless people value the work, the unseen work that teams like that do, and put it into a system level thing and make the hospital understand the value, the police understand the value, the fire brigade understand the value, so forth, you won't resource in the most intelligent and kind way. And I think that the problem is that if the ICSs rely on us to always be trying to fight to say, no, listen, you need to value me as a GP because I do loads of good, and third sector needs to also shout out, and the problem is that we don't do the data, that's not fair, that's not true. They're the ones who are responsible for a collective environment, and they need to manage us as an environment where we're all interconnected, we're all trying our best, and that's where the opportunity is. And the acutes are so much better at that. I was at a meeting about primary care, community care. Most of it was acute sectors talking about how great they would be if they could do more, have more money to work more in primary care, more in community care. And the thing they were very good at describing was the follow-up burden of how good they were, but then they had to manage this, had to manage that. And it made me realise how much stuff happens within community spaces, primary care, third sector, but we're not very good at explaining it, one, and two, people don't want to hear it. They don't want to, so unless it's a proactive, inquisitive approach from ICS to look for that, to understand and to help us belong in that future and to value us, then we can find collective solutions where everyone will have a place, something to be proud about and so forth. Until we do that, I think we're just in a conflict situation.
Tom, thank you. Have we got two more, David, is there? That's general practice in Wilmslow, general practice in Wirral. I think we're going to go to London. Is that? Yeah, Paul?
London. Look, part of the solution, it strikes me, is that general practice and primary care workers have got to become much better understanding of evaluation. As long as evaluation is using this sort of targeted, secondary, focused approach, you're talking about laboratory research. We live in the real world where complex things happen. Transformation happens not by manipulating it, by multiple co-adaptations as all parts of the system micro-adapt to each other to create a new kind of system. That's not inside the thinking of traditional evaluation. General practice needs to lead a modern, more appropriate approach to evaluation.
Paul, thank you. Is there one final? I saw one. Linda. You have the final say, Linda.
Gosh, I feel very privileged, thank you. I just want to say, from the point of view of somebody who's not a general practitioner, I've heard so much about the angst, the concerns, the loss of opportunities. I just wonder We are, as you say, in a state of flux. We're about to move to a general election. Are we going to influence things so that it does get better, so that community-orientated practice actually starts to be recognised and appreciated in the way it should be? The stuff that you guys are doing needs to be actually funded. It needs greater understanding of how to promote it. I just think we need to get to those politicians and make them think differently.
That's a helpful finish. I think we're going to have to draw it to a close, and Sue, you're going to be coming on stage next anyway, so you can. But I think it's unfair to say to try and answer those questions. I think it's more about comments and issues that are challenging the service and things and the enthusiast to make it change. But any final comments?
I would say one thing. I think what I hear a lot from particularly primary care ICB colleagues is that there is a frustration that they don't necessarily feel seen or heard either at that ICB level. One of the things that I found really interesting is we've been testing this thing called Improvement Week, which is essentially collaborative improvement in different systems where you use a single practice or a PCN as a bit of a kind of a base. And every piece of work that is managed for a week is examined, and there's a control room. And to your point, Thomas, you have the ambulance service there, you've got voluntary sector, you've got patients, you've got the acutes, you've got all of your system partners round the table from 7 a.m. So they come in at 7 a.m. and then they come back at 7 p.m. And you look at all of the data points. I think they looked at like 33,000 data points. It's quite intensive. And you look at what work could have gone where, whether it's appropriate, but you also start to identify all of the work that is happening. So the stuff that we're starting to talk about that might be hidden, not seen. And what that has, it's been interesting, because what that's done is it's done some kind of, there's been some improvement, sort of transactional improvement, where this is a problem here, the system takes ownership and takes it away to fix with the appropriate system partners, and that can have a big impact across a wide range of particularly practices in this instance, because it's not just isolated to that practice. They find practice level improvements or PCN level improvements that they can make, great. But what it's really helped to do is one, build an understanding of primary care that didn't exist. It's helped bring stakeholders together around a common purpose, which didn't exist. And it's actually empowered people. So there's a team that helps facilitate, but after a couple of days, they kind of hand it over to other people so they can continue and really drive that forwards, which then starts to build a bit of an infrastructure to continue this kind of way of working. And I think then through the use of data, so it will move away from anecdote, it moves away from blame and frustration. They use the data and they can just see what's happening, and it's really centred around people and patients and the communities. And that has been a really positive intervention or initiative to start to drive the kind of integration that we're talking about, to start to drive the understanding of the value that this work can bring, and flag some of the hidden work that isn't necessarily kind of measured, as we've talked about, but actually has then been invested in to continue. So I think, there are opportunities, there is lots of good stuff that is happening. Recognise all of the constraints in which we are working, but I do think, and maybe I'm glass half full optimist, but I do think that there is stuff that's in our sphere of influence without, I completely agree, we need to influence the politicians. We need the whole structure around us to support that. But I think there is stuff that we can even do now that will help make things a bit better.
Minal, thank you. We're going to draw this to a close, and I think we recognise that what a gig that is. National Director for Primary Care Transformation, and all will be done in this fiscal year as well. So we're not underestimating the work you're doing, and thank you for that, and thank you for the sort of candid and reflections you've shared with us today, and hopefully you've found some useful reflections from the audience as well. But before you leave, in time or fashion, please could you join me in thanking Dr. Minal Bakhai. We're going to move straight into the panel discussion before we have a break and then sort of summarise